This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So this is what I'm going to be covering today. I'm going to be covering some U.S. statistics for limb loss. And even though we're going to be talking about traumatic amputations, since more than half of the amputations that occur in the United States are due to vascular causes, it would be remiss of me not to mention vascular causes for amputation. We're going to talk about prevention a little bit, and then we're also going to be talking about rehabilitation after surgery and as well as pre-prosthetic care. And I'm going to be segueing the topic then to Artie, who's going to be talking to you about some of the advances in prosthetic and pre-prosthetic care. So there are about 185,000 amputations per year involving the arm and the leg. And the hospital costs that last toll in 2009 are at least $8.3 billion. So if you can imagine, that's now 7 years ago, so it's significantly higher than that. And that doesn't even include the rehabilitation costs, it doesn't include the prosthetic costs, and it doesn't include the emotional costs, certainly, with amputation. It doesn't include also the cost with work lost following an amputation. And as of 2012, there were at least 1.9 million people living with limb loss. So here's kind of the breakdown in terms of individuals who have amputations. You can see that vascular disease accounts for a little bit more than half of the individuals who undergo amputation, followed by trauma. So we're first going to address those with vascular disease. So the peripheral vascular disease refers to circulation disorders involving blood vessels that are distant from the heart and the brain. And peripheral artery disease is the most common cause of peripheral vascular disease. And with it, you see narrowed arteries that decrease flow of blood to the arms and leg, which put people at risk for amputation. There are a lot of people who actually have peripheral artery disease, at least 8 million Americans, half of which have no symptoms of the disease as yet. And certainly the most severe manifestation of the disease is loss of circulation to the limb, which of course puts you at risk for limb loss or amputation, as well as risk for mortality. So here are some of the symptoms: painful cramping, achiness, fatigue, and burning, and those are fairly nonspecific. Some of us who are weekend warriors or get out there and do too much gardening or exercise at one time can have these same symptoms. But what's characteristic of people who have peripheral vascular disease is something called claudication, which is cramping leg pain that's worse with walking, and that's due to abnormal circulation. These are the risk factors for peripheral artery disease. And as you can see, the first three are some things that we can't really modify. So they're non-modifiable risk factors. That is, you can't really modify your age to decrease your risk of peripheral artery disease, nor can you change what family diseases you have, nor in some cases you can't really impact your own history of heart disease or stroke. Unless there are some ways to do that. And actually, these are the modifiable risk factors for peripheral artery disease. And that is stopping smoking, controlling diabetes, or working with your diet to avoid diabetes, also avoiding high cholesterol, high blood pressure, getting out more and exercise, and watching our weight. And these are all things that we all know are necessary to keep us all healthy. Diabetes is a disease process that can also put you at risk for amputation due to impaired circulation, not only in large vessels, but small vessels. Also associated with diabetes is neuropathy. So it's impairment of the nerves such that the nerves don't function as normally as they should, and you can sometimes have numbness or tingling or lack of sensation, particularly to the feet area, which increases somebody's risk of damage to the skin. So if you can imagine, you don't have if your sensation is impaired in your feet area and you're wearing tight shoes, if you can feel it, you take your shoes off or you give your feet a rest. But if you're diabetic, you may not really perceive that there is numbness in your feet, and you can actually take off your shoe and suddenly find that your skin had broken down, or you have irritation or abrasion to your skin that you were unaware of. That leads to the risk of foot ulcers or skin breakdown that is significant and can put you at risk for infection. Those with diabetes have a 15 times more likely chance of undergoing an amputation versus the general population. Diabetes is the leading cause of amputation in the lower limb. And it's for this reason that we really have to look at prevention, and we can impact the rate of limb loss or amputation by doing preventative measures to avoid development of skin breakdown. And that is to learn how, for those with diabetes, learn how to care for your diabetes so you keep your diabetic sugars in close control, and that remember to inspect your feet or check out your feet at least twice a day to make sure there's no undue irritation that's occurring to the bottom or the sides of your feet. In addition, it's important that clinicians follow you on a regular basis to check at your general checkups to make sure that you're not developing any sores or evidence of skin breakdown to your feet that could lead to infection. And for the typical primary care physician, it's sometimes hard to do all of those things, to educate and to follow regularly and to watch your sugars and to do all of those things by themselves. So what different people have done is put together teams of people, teams of experts, or an interdisciplinary team of clinicians to help in a clinic setting or in a coordinated effort to try to prevent skin breakdown due to diabetes, and also to treat it and recognize any problems early on. They've done that in several different countries. In the United Kingdom, when they put a team approach into place to try to prevent and monitor closely patients with diabetes, they saw a 62% drop in major amputations in these individuals that they were working with. They found the same thing essentially in Sweden as well, a 57% drop in major amputation by instituting a team approach to care. That could be an endocrinologist, it could be a surgeon, podiatrist, radiologist, all these different peoples with different level of expertise that can come together and really closely monitor and provide education for people with diabetes. Same with in Spain, a 60% drop in major amputation when they instituted the team approach to care. And a lot of organizations in the United States are working together to develop evidence-based guidelines for people to follow so they can also create an interdisciplinary team model of care for diabetic patients or even vascular patients to try to prevent amputations from occurring. And that includes the American College of Cardiology, the American Heart Association, the American Diabetic Association, and even the Veterans Administration. So now we're going to switch gears a little bit and talk about traumatic amputation, which is about 45% of the causes for amputation. The most common mechanism of injury is blunt trauma. For upper extremity amputations, it's blunt trauma due to a motor vehicle crash. And for lower extremity amputations, it's due to motorcycle crashes and pedestrian versus auto accidents, which are actually, we have a fairly high rate of pedestrian versus auto accidents here in the city. It occurs with young males, and the most common level is below the knee. That's also known as transtibial amputation, so below the knee amputations. The prevalence, or the number of people in the United States that are currently living with limb loss, is projected to double by the year 2050 to about 1.3+ million people. And then this number rises in part due to the increased life expectancy that we see in our population. So if you can imagine, there's a whole lot more people undergoing amputation. There's got to be a good way or a better way for us to manage their care, to provide them with education, because care of the patient who has undergone this type of surgery is really lifelong. So how do we manage that in the most effective way? Pasquina is a researcher who, he and his colleagues, and this is kind of a busy slide with a lot of little letters here, and I'll tell you what it says, looked at the providing a framework by which multiple clinical disciplines, in this case it was the military, could work together to really look at the patient from the time before surgery all the way to the time that they've had surgery, when they get discharged home, and into the future, because you have to follow these individuals for the rest of their life. And what you can't see here, because it's too small, the letters, are a variety of different clinicians, surgeons, orthopedic surgeons, internists, rehab individuals, taking care of people in the inpatient setting, and then providing social services, outpatient follow-up with surgeons, the rehabilitation staff, prosthetics and orthotics from the very beginning, and then taking that out to the outpatient setting and then really providing that same level of care throughout life, because this is a lifelong process, because you're constantly going to be having to monitor skin, to look at different prostheses over time, monitor the status of the prostheses and whether they're in disrepair or in good repair, or if it needs to be changed depending on a patient's individual function. In general, to provide comprehensive care for patient undergoing amputation, it really does take a village. And fortunately, here in San Francisco, we have our village here at Zuckerberg San Francisco General Hospital, which is a level 1 trauma center. Because it's a level 1 trauma center, we see the vast majority of people who undergo traumatic amputations at ZSFG. And also we see quite a number of people who undergo amputations due to vascular causes as well. And our village there, because we're a level 1 trauma center, we have a lot of expertise under one roof. We have rehab docs like myself, orthopedic surgeons, trauma surgeons, vascular surgeons, plastic surgeons, podiatrists, prosthetists, rehab staff, specially trained nurses, and for our functional limb service, we have a team coordinator. So when we started to look at our ability to treat patients who are at risk for amputation or who have already undergone amputation, we wanted to get together and see what could we do to make the care better. So we got together, put our heads together, and developed what we call the Functional Limb Service, now known as FLS over at the General. And we utilize all the different expert opinions of these clinicians to try to help decide what's the best course of care for an individual, if we can, before they undergo surgery, and certainly through all levels of their care. We are hoping that in the future we'll be able to add a nutritionist, an infectious disease person for those who have infections, endocrinologists for people who have diabetes, social services and case managers who can provide resources for our patients, a vocational rehabilitation counselor, and a program facilitator to help us out in the future. So we're still growing as a service, but it's great to know that we're all together and sort of in it together to help to improve the care of patients with amputations. Our goal really is to help, number one, to prevent amputations from occurring, if we can, by early identification and treatment of at-risk limbs, by utilizing team input from all the different services and all the different clinical experts to maximize functional outcomes, and to provide patients and caregivers with education that will help them with decision-making and recovery. What we do is we look at individual clinical cases. We can provide inpatient consultation when patients are admitted if there are questions about amputation. We provide outpatient follow-up clinics that are interdisciplinary. It's kind of a cool day when we have FLS clinic, because not only is the prosthetist there, I'm there, the therapist there, the orthopedic surgeon is there, just down the hall is the vascular surgeon, the plastic surgery service. We're all having clinic at the same time. So you may see us kind of bebop from room to room if we think that somebody needs to see another clinician that they may not have been otherwise scheduled for. It works out nicely that we can pull somebody else into the room if we need their advice. In addition, we also have started peer mentor and support groups for individuals who are at risk for limb loss or who already have had their amputations, and we're constantly assessing the need to improve our service. So how does it start? Before surgery, if you are somebody who has a vascular cause for potentially an amputation, usually you're being seen in a clinic already. And at the clinic, outpatient clinic visit, if it's determined that something is in decline or something needs to be done that will require an inpatient stay, then that can be determined in clinic and a person is admitted to the hospital. For those who come in with trauma, we can't really do this obviously. They just come in and they're admitted to the hospital. So once in the hospital, they can get a team assessment from the different players of FLS to look at what the surgical considerations, which would be what level of amputation would be best for the patient based on whatever damage there might already be to the limb due to infection or to trauma, and then what level would be best to promote the most functional amputation level possible. In addition, this is a time for us to provide the patient with as much education as possible so that they can make informed decisions and we can guide expectations so they won't be surprised down the line when we say, okay, now it's time for rehab and now we have to go start looking for, we're going to do some standing or we're going to be moving around in bed post-operatively, so they're not surprised. So when they have surgery, at the end of surgery, there are a couple of different choices that we can do in terms of beginning the rehab process and the pre-prosthetic fitting process. One is we can potentially place a rigid dressing on the limb, which a rigid dressing as opposed to just a big bulky bandage wrap will help to confine the residual limb a little bit and help to reduce swelling right away. Now, it's good to reduce swelling, but in some cases it may not be for everybody because if you have an amputation site where the wound needs to be closely monitored, you don't necessarily want to cover it up with a cast or a rigid dressing. For a select number of patients, we have something called an immediate postoperative prosthesis or an IPOP. And the advantage of this is that we put on a rigid dressing and you can connect a pylon and a foot to the end of it so you can have the potential for early weight bearing. Now, this is not for everybody. The good part is it can reduce swelling right away, and it provides for the potential for early weight bearing if the surgeon thinks it's safe to put weight on the wound. And it's just a little bit of weight bearing, not a lot. But from a psychological standpoint, it's nice to know that you can actually start using your limb after surgery. Some of the things that need to be considered is we'd only consider this if somebody is really good at following instructions, because there's only a limited amount of weight you can put on the limb, and it's not optimal for diabetic patients because, as we said before, the end of the residual limb may be numb because of the diabetic process that's in place. After surgery, some patients are surprised because we start the rehab process really early on. And the rehab process can begin with something as simple as bed positioning. I don't know how many people have been in hospital beds, but the first thing we tend to do is we lift the head of the bed up and then we put the feet up, so now we're kind of like in this little chair position. That's not good for somebody to be in for a long time after amputation surgery because it keeps your hips bent and it keeps your knees bent, and the problem with that is if you stay like that, it starts to get stiff and you can develop what we call contractures or an inability to stretch it out to its normal range. The prosthetist really needs good range of motion at the hip and good range of motion at the knee so it's not stuck in a bent position to fit somebody with a prosthesis. So we really want to encourage what we call proning or side lying. So here's an individual who's proning to make sure that we're stretching out his hip flexors or the front of his hips to prevent the hips from curling into a bent position, and also trying to keep the knee straight. We also want to keep the knee extended in a wheelchair. So wheelchairs have special extensions to keep the leg in a stretched out position so that the knee doesn't go bent. So what do I mean by this knee becoming bent? So here's an individual who unfortunately spent a lot of time in the wheelchair. He has amputations to both of his legs, and his knees became bent over time. Well, we couldn't fit him because he was so bent. So what we needed to do was to work with basically unbending his leg. And what we did is we started with serial casting, which is basically stretching out his leg as much as possible, casting it, and then leaving it that way for a week, taking off the cast, stretching it some more, casting, and stretching it over, actually it was over a month to 2 month period. So what we did here is we actually cut the cast in half. That allows us to open up the cast so the nurses can check and make sure the skin is okay. And it also allows the therapist to work with the leg outside of the cast. And when they're done, you put it back in the cast, you wrap it up so that we sustain that stretch. So here he was at the beginning of serial casting, and here he was at the end to a point where we could actually go ahead and start to fit him with the prosthesis. It worked for him, but the problem was we lost valuable time in moving towards prosthetic fitting for him because we had to go through the process of unbending his knee. We also want to continue with wound care, monitoring that closely as an inpatient, also as an outpatient. We want to keep the suture line clean. We want to keep everything dry. Then we introduced a shrinker sock to try to, you pull it onto the residual limb. It helps to mobilize some of that edema that comes after surgery so that the edema moves up the leg and the leg can start to shape into a more conical form. So here's an example of a stump shrinker, and also an example of a limb guard which can protect the limb so it doesn't get bounced around. And for people who have a below knee amputation, if you put your leg in here, it keeps your leg nice and straight. Physical therapy can never start too early. We're going to be working about moving around in bed. We're going to start stretching, range of motion, and we're going to be doing pre-gait activities like standing, moving from sitting to standing, and walking. Same thing in occupational therapy. They work a lot with activities of daily living, dressing, bathing, feeding, grooming, showering, all of those activities. They'll be working early on with patients as well while they're inpatients. In addition, they look at equipment assessment, wheelchair use, special commodes, reachers, anything that can help to assist the patient to do activities in a safe way. So here's the process. We've had our surgery. We're going through rehab. We're learning how to get in and out of bed to a wheelchair using a front wheel walker, and for those who are advanced enough, beginning to navigate on stairs. For some people, after this period of time, they may be ready to go home. So if they're able to achieve moving about either in a wheelchair, they have support systems at home that are conducive to going home right away, if there are no stairs to overcome, going home with outpatient therapy is a potential possibility for them. These are the activities that you could be doing in outpatient therapy, standing and practicing single limb stance, and also working with transfers on and off toilet, on and off the shower chair. These activities are important for safe activities at home. For some people, they need an inpatient rehab stay, sort of a pit stop if they're not able to do these activities by the time they're ready to get discharged from the hospital. After they can perform these activities, they can then go home, again with outpatient therapy, to continue some of those walking tasks as they prepare for rehabilitation. So during this time, their wound is healing. We're shaping the stump with the stump shrinker, and we're starting to see them in outpatient clinic. We start to have the sutures removed, typically 3 to 4 weeks after surgery, ongoing stump shrinker use, and you can see here how the stump can change shape over time. From 3 weeks to 8 months, you can see that the stump is moving from sort of this bulbous formation at the end to something much more conical. And it's important to go through this process because the fit of the prosthesis is going to depend greatly on the shape of the stump. All right. Again, here we are. The other thing that we're looking at is during this period of time, even before surgery in some cases, assessing a patient's ability to use a prosthesis. So we always ask the question, can a patient safely and successfully use a prosthesis? And what does that mean? We want to know what their prior functional status was. Were they active? Were they exercising? Did they jog? Did they run? Or were they, because of different factors, maybe heart disease, they had a heart attack before, their endurance is limited, was their walking limited to just moving from their bed to the bathroom and maybe just within the home? Further, we want to know whether or not somebody is good at following instructions, their thinking processes. Can they remember to ask for help? Do they remember the steps in putting on their prosthesis? Do they know what to do if they find skin problems happening on their prosthesis? Do they know when not to use their prosthesis? All important considerations to determine if somebody can use a prosthesis successfully. We also look at function in terms of energy. It takes more energy to walk with the prosthesis than to walk without one. So here we measure energy by metabolic equivalence. So one metabolic equivalent is actually what you guys are doing right now, which is basically sitting and watching a lecture. That's one metabolic equivalent of energy. 3 metabolic equivalents, or 3 METs, is normal walking. So if somebody is walking with the below-knee prosthesis, it takes about 3.3 to 3.8 METs to walk, which is about a 9 to 28% increase in energy, which for some people, if they're very active and they're athletic or whatever, they don't have a lot of other medical problems, that may not be a big deal. But for somebody whose endurance is limited, who have other medical problems, this may be a big deal. So we have to take that into consideration. The higher you go, let me just add this. So walking with a prosthesis would be akin to doing moderate type of activity, exercise activity or moderate walking. The higher you go up in terms of your level of amputation, from your below the knee to through the knee or above the knee, it takes much more energy to walk. So for this individual, they had a hemipelvectomy. So basically, because of trauma, half of the pelvis had to be taken off along with the limb. It takes 6.75 METs for somebody like this to walk with a prosthesis like this, 125% increase in energy to walk with this type of prosthesis. And that's akin to jogging. So as you can see, it's important for us to take these things into consideration when we are trying to see whether or not somebody is going to be appropriate for a prosthesis and what kind of prosthesis. So here's a segue for the next speaker, Artie. You're going to be introduced to something called K-levels. Now, Medicare and other insurance companies utilize K-levels to help determine what type of prostheses somebody is going to need. K-levels refer to levels of functional activity. So for example, if somebody is the type of person at home, they really walk mostly in the house, but when they go outdoors, they're using a wheelchair because of whatever reason. Kidney disease, they're in dialysis, or they have other comorbidities, heart disease, COPD, lung disease. Then they may be more appropriate for a K1 prosthesis, a prosthesis that's stable, that's simple and easy to care for. But if you happen to be somebody who's very active, you're an athlete, you run, you might be somebody who's more appropriate for a K4 level type of prosthesis. So more for energy storing feet. This could even apply to kids as well. Energy storing feet. If you're an above the knee amputation, you need a prosthetic knee joint, then you're somebody who may have a knee joint that is a little bit more complicated to use. Somebody who's more sedentary would have difficulty coordinating use of their limbs to use that type of knee. But somebody who's really coordinated and rigorous, wants to start and stop and move at different cadences or speeds, it may be appropriate to have more of a K4 level need. So think of the K levels when Artie starts talking, because she's going to talk about some of the K levels and as they relate to different forms of prostheses. So just in conclusion, this was sort of a real rush through amputation, an introduction to vascular amputations, to traumatic amputations. There's prevention that can occur to prevent amputations from occurring, especially in diabetic patients that require a team approach. And likewise, it requires a team approach of care to really effectively determine what are the best surgical levels for amputation and what does it mean for somebody in terms of recovery and function. And that's why we have our functional limb service at San Francisco General. So the team approach of care is important to prepare the patient for prosthetic fitting as soon as possible and to help patients set and achieve their functional goals. Thank you for your time.
Good evening, everyone. Welcome. I'm really excited to be here and talk to you guys today about amputation and prosthetics. My presentation today is going to be the cool one. I have no statistics, none of that information stuff. I mean, there is basic information, but it's not all the high-end statistics for you. It's going to be mostly the cool stuff in prosthetics. And we will be taking any questions at the end. So as Dr. Pascal spoke about K levels in the functional level of amputees, we're going to discuss the, each individual K level and what does that describe in terms of these amputees. So functional level K0 is what we start with. The functional levels go from 0 to 4. So functional level K0 basically describes a patient who does not have the ability or the potential to ambulate or transfer safely, whether it's with or without assistance. And in this case, a prosthesis will not enhance the quality of life or any mobility. So basically, you're looking at an amputee who has other comorbidities. It could be heart conditions, it could be lung capacity, it could be a wound on the other leg, any kind of health issue that would prevent the patient from walking and ambulation. In this case, patient is usually bedridden or wheelchair bound. So obviously, in most cases like these, we either wait until the patient's condition changes, improves, and if they advance to a level 1. So the functional level K1 is where the patient has the ability or the potential to use a prosthesis for transfers and ambulation on very level surfaces and at a fixed speed. So this is our basic level amputee here. Very typical of a limited in-house or an unlimited but a household ambulator. So not somebody who's very active. Patient is usually in a nursing home or is homebound. Most commonly, the amputee is using an assistive device such as a cane, crutches, or a walker to ambulate. We will also look into different prosthetic components in relation to these K levels. So when we're talking about insurance justification for prosthetics, Medicare has set standards that each K level is justified, or each prosthetic component justified for specific K levels. So during our process, we identify the K level as step 1, and then identify what prosthetic components will go for that specific K level. So talking about functional level K1, the prosthetic foot or the feet that would be considered would be a solid ankle cushion heel, which is also called as a satch foot. The simplest type of foot in the non-articulated style is this satch foot. The keel or the inside structure is very rigid. The ankle action is provided by the rubber bumpers or the rubber heel that compresses as the patient strikes the heel on the floor. So as there is heel strike, the rubber bumpers compress and provide a spring kind of motion. The rubber heel wedges are available in 3 different densities: soft, medium, and hard. So it's a pretty basic foot. The advantages with a satch foot are that it's a very stable foot and provides very good balance for weaker patients. And the disadvantages in certain cases could be it has absolutely no movement. For an above-the-knee amputee, the other component that comes into picture is the prosthetic knee. And in a functional level K1, you're looking at mostly manual locking knee or a safety knee. The manual locking knee is locked completely in a straight position whenever the amputee is walking, and can be manually unlocked with a switch on the side to allow the amputee to bend the knee and sit. Then when the amputee gets up to walk again, it locks automatically again. The safety knees actually contain a weight-activated friction brake that basically stops the knee from bending. So the knee swings freely like a door hinge when there is minimal or no weight on the prosthesis. But as soon as the patient attempts to put some weight, the knee joint, the break in the knee joint locks and prevents the amputee from buckling. Again, advantages with the manual locking knee is it's a very, very stable knee, especially for less active amputees who have problems with balance. And the disadvantage is it does not allow the amputee to walk at different walking speeds. So it's a very constant, same speed walking. That can cause a little bit of abnormality in the gait when you're walking, especially when somebody is walking with a locked knee, which is going to end up with a more circumducted, abnormal-looking gait. And it does require the switch operation for locking and unlocking the knee joint. With the safety knee, it provides, again, more stability for locking for the low-level amputees. The concept with the safety knee is that it will lock until about 35 degrees of knee flexion. Beyond that, it will not lock even if the patient's weight is on the prosthesis. So that is a compliance issue, and that is a training issue for the patient that we have to make sure they're trained for it. Again, with the safety knee, the amputee cannot walk at different walking speeds. Next, we come to the functional level K2. This is where the patient has the ability or the potential for ambulation to traverse on low-level environmental barriers, such as curbs, stairs, and which is typical of a limited community ambulator. So this is not a very active person. It's a very local community ambulator, not doing any recreational activities included in that. This amputee may or may not use assistive devices as needed, pretty much. So the different prosthetic feet used for or considered for a K-level functional amputee is the single-axis foot and the multi-axis foot. The single-axis foot is a single axis, like it specifies, so it's just a one joint which allows kind of a front-back movement within the foot. Provides for ankle movement that is controlled by two rubber bumpers, one in the front, one in the back of the ankle joint, which can be changed to allow more or less movement. So it comes in, again, different densities and different stiffness. Depending on whether it's a transtibial or a transfemoral, meaning a below the knee or an above the knee amputee, that can vary depending on how much stability the patient wants. A multi-axis foot is often recommended for people who need to walk on uneven terrain because it also allows some sideways movement to compensate for, say, walking on a rough, sandy surface or walking on a ramp. The multi-axis foot actually has more components to it and hence is slightly heavier than a single-axis foot. And it also requires slightly more maintenance than a single-axis foot. The prosthetic knees that are considered for a functional level K2 amputee is mostly weight-activated or the safety knee, like we had for the K1. But this may also include a spring assist, spring extension assist, which means that now we have something that is helping the amputee bring the knee forward or kick it forward to get a little bit of more resistance or less resistance to the knee as they are walking. Again, the weight-activated stance knee with the spring extension assist allows for a much smoother gait, a more natural gait when the patient's walking with least amount of noise. It's pretty strong, sturdy, lightweight design that incorporates the stance control feature, meaning the brake feature, and has connectors on both sides. Next level is the functional level K3, which is the patient who has the ability or the potential for ambulation with different walking speeds. This is a very typical community ambulator who also has the ability to traverse most environmental barriers and may have vocational, therapeutic, or exercise activities that demand prosthetic use beyond simple locomotion. So most of us here probably would fit under the category functional level K3. It's a pretty active user that we need a prosthesis for vocational as well as recreational use. And K3 level functional activity amputees will not use assistive devices while walking. So the prosthetic feet used for level K3 are mostly dynamic response foot, energy storing foot, and multi-axis. So the names itself speak for what these feet kind of do in terms of dynamic response, meaning they actually store energy as the heel strikes the floor, and then as the patient comes up on their toes, it kind of gives that energy back, helping propel the patient forward easier. So it reduces the energy consumption as the patient is doing higher activities. The energy storing feet are designed to store and return that energy during the gait cycle to assist the patient with advancement and walking. It's very fluent movement, and the multi-axial movement within the foot, again, helps walking on uneven surfaces, ramps, and stairs. Now, I know the pictures on here show just the inner structure, and these are just the design of the prosthetic feet. All these feet are covered by prosthetic covers that pretty much match the patient's shoe size, patient's skin, so they are like skin tone and size adjusted. The pictures just depict kind of the inner structure. The K3 level prosthetic knees that are applicable are the pneumatic knees, hydraulic knees, and the microprocessor knees. When we say pneumatic, hydraulic, and microprocessor, what these actually do is just control the swing and the stance of the knee, so the functioning of the knee. The pneumatic knee basically has a pneumatic cylinder within the knee that is more responsive to different walking speeds. So as the patient changes from slow speed to a fast speed to going to their medium strolling walk, the knee will kind of respond accordingly. It's a more advanced form of swing control than friction or the spring. Because the air is compressible, it acts as an extension assist within the pneumatic unit. The hydraulic is a little bit more advanced than the pneumatic, where the wearing control is caused by the characteristics of the hydraulic, which is the fluid, through different ports within the knee joint, where the resistance to flow increases with increasing walking speeds. So if the pneumatic knee joint usually has a range for the patient's walking speed, then the hydraulic knee will have a wider range. So it will cover further slower to further faster walking speed for that amputee. The disadvantages of some of the pneumatic and the hydraulic knees are pretty much, they are mechanical knees with air and with fluid extension assist within them, so they do require maintenance regularly. They are slightly heavier in weight compared to like a friction or a spring assist knee joint. But they do provide much more easier walking for the amputee. And they are slightly more expensive. Obviously not as expensive as the microprocessor knees, and we'll talk more about the microprocessor knees in the further slides. So our next functional level is the K4, where the patient has the ability or the potential for prosthetic ambulation that exceeds basic ambulation skills, exhibiting very high impact or stress or energy levels. So it's a very typical of a person who is into very high-level recreational sports, competitive sports, anything that really requires that high impact or stress coming on the residual limb. You probably have seen a lot of these in like the Paralympics and different advertisements on TV. The important thing to understand in this aspect is when we specified initially how Medicare and the insurance companies, I hate to say the word dictate, but want us to justify what we are doing. So when somebody comes and says, we want a running prosthesis, we just need to make sure that they fit into this category and they can actually justify having or doing those kind of activities. So the prosthetic components in terms of feet and knees, the prosthetic feet are the shock-absorbing feet, so they are slightly different designs. If you see these blades here, they do have rotational or torque capabilities within them. The prosthetic knees are the pneumatic or the hydraulic knees with the very high activity frames, considering how much impact is going to happen on these prosthetic knees. Some of the above-knee amputees that participate in the Paralympics actually don't even have knees. So they actually have just a stiff knee, because then that is less movement and less stability issues, especially when they are running or doing higher activities. So talking about that, just different designs of the running prosthesis. These are very unusual. So you wouldn't really see anybody walking on the street with blades like these. These might not be very stable to walk on. We probably rarely have any amputees who walk on these as well as be running on them. But these are meant for specific activities. And then the biking prosthesis, like in this case, if you see, this does not even actually have a prosthetic foot on the bottom. So it has like a block that can be attached to the biking pedal directly. So these are just modifications that can be done for functional level K4 amputees. So to talk about the basic anatomy of a prosthesis, on your left is a transtibial or a below-the-knee prosthesis, which basically means the amputation is done anywhere below the knee joint, and the knee joint is present and is in good range of motion. When we start with the rehab process, like Dr. Pascal was mentioning, we do consider having the existing joints completely, be in good condition with full range of motion, muscle strength, be strong. So all those things are considered. The top part is called the socket, and this is what actually fits on the residual limb. We need to ensure that the fitting of the socket on the residual limb is done correctly. The major functional outcome of the prosthesis depends on how well the socket fits on the residual limb. There was also a slide in Dr. Pascal's presentation that spoke about residual limb changes over a period of time, and that's why it's also important. We want to stabilize the residual limb as much as possible before we start with the prosthetic fitting, so that once the fitting is started and accomplished, then there is no major changes. In spite of that, we still expect the residual limb to start toning and shrinking down within the first 6 months to a year, at which point we have to replace the socket, which is that top portion, without having to replace the rest of the prosthesis. So the advantage of having a modular prosthesis is that you can actually remove and replace any specific component without disturbing the whole prosthesis. So the socket in this condition, in this picture, is attached to different components in between, and then is attached to a prosthetic foot. The prosthetic foot, like we discussed prior, is determined by understanding the specific patient's age, his activity level, what kind of things he did before, what specific requirement the patient has, and accordingly kind of have a mutual agreement to what prosthetic foot would be most applicable and beneficial for that patient. To your right is a above-knee prosthesis or a transfemoral prosthesis, where the amputation was done just above the knee. So the knee joint is missing along with the ankle joint. The hip joint is still present and is in good condition. So here again, the socket that fits over the residual limb is the crucial part. In an above-the-knee prosthesis, in this case, the socket, I hate to say that it's more important, but it's really needs to be carefully designed and fit, because if you can actually picture the weight-bearing surface for this socket, which is in the back here, is kind of right, it's on the ischium, which is on your seat bone. And so you're kind of dealing with going more in the groin area, around your gluteal fold, which can get very uncomfortable. So the fitting of a above-knee prosthesis or an above-knee socket is probably more complicated than a transtibial or a below-knee socket. So this socket is then attached to a prosthetic knee, like we discussed for every K level, along with different components and attached to a prosthetic foot at the bottom. A few things that I would like to just mention when we're talking about different parts of the prosthesis is most prosthetic feet and knees are aligned in a specific way to provide stability to the amputee. These can be fit with any kind of footwear, shoes, sandals. There is certain recommended ones and certain ones that are not advisable. Like we don't advise amputees to wear 4-inch heels with their prosthesis. That would make them very unstable. So these are things that we kind of train them, teach them. But most shoes, yes. The other thing we need to also tell them is the alignment is usually defined as per a specific shoe. And if you're drastically changing your shoes in terms of heel height, then you have to make sure the alignment is adjusted accordingly. So these are concepts, like if you see in this transtibial, if you see it's slightly leaning backward, but if we put that in a shoe, then it would probably straighten up a little bit. So that is kind of the alignment that can make a patient's balance or stability, like it can affect a patient's balance or stability. So that's really important to understand. So the different steps that we go through with an amputee is once the decision has been done to amputate, and the amputation surgery is happening. So we come into the picture sometimes even before the amputation surgery happens in terms of consultation with these amputees, talking to them about what's available, what their options are, and explaining the process just so that we can reduce the anxiety of the unknown, basically. In certain cases, like in severe traumatic amputations, we don't have that opportunity. But we do like to come in as much as possible before the surgery. So once the amputation surgery is done, the drains are removed, and the suture line is completely dry, that's when we fit the amputee with shrinkers, whether it's transtibial or transfemoral, and limb guard. Now, limb guard is basically a device, a plastic-made, custom-made device that fits on the residual limb, and it's just in order to protect the residual limb from any kind of damage. Most amputees, when they get up, still have the sensation that the residual limb or their leg is still there. That is called phantom sensation. They can also have phantom pain, meaning they can feel pain in the foot that is not existent anymore. So we've had incidents where the amputee can try to stand, considering they have both legs, and try to walk. So to prevent any damage to that residual limb, we provide them with the limb guard. Once the sutures are completely removed and the limb is completely healed, we do an evaluation for that patient, establish the K level, submit for authorization to their insurance. So basically, this is the back-end paperwork that we need to do. Work with the physical therapist on attaining the goals for their muscle strengthening. Once authorization is received, we schedule the patient for a casting appointment. From amputation surgery to a casting appointment, depending on how long the stump takes to heal, could possibly take around 4 to 8 weeks. And then from our first casting appointment to the time that the patient actually receives the prosthesis, it could possibly be another 4 weeks on an average. So we go through a couple of trials with the prosthesis. We go through a final fabrication. We go through training to make sure that they can take the prosthesis on and off. They know how to use it. They know how to change things around if they have to. And then comes the final prosthetic delivery. With most of our prosthetic patients, we have a lifelong relationship, meaning initially we do an appointment, a follow-up appointment every 2 weeks, and then gradually it moves to every 3 months or 6 months and annual. But it's always a constant follow-up. These are all mechanical components. They just need servicing, just like you would with your cars and other mechanical devices. And they might need replacements at some time. So we just need to make sure that everything's working appropriately. Now we're going to talk about the high technology in prosthetics, the cool stuff that you see on TV. So the microprocessor feet basically are where there is electronic component within these prosthetic feet. Microprocessor controlled prostheses usually have sensors to adjust the joint movement on a real-time, as-needed basis. So the ankle joint control is intended to improve the safety and the function, and it's specifically for patients who have the capability to move at different walking speeds and different surfaces. So it's not just for stability or balance, but it is for more active user as well. So with sensors in the feet that actually determine the direction and the speed of the foot's movement, the microprocessor controls the flexion angle of the ankle, allowing the foot to lift during the swing phase, potentially adjusting to different changes in the force, speed, and the terrain during the step of the prosthesis. So the goal of these microprocessor feet is to make walking more fluent and to prevent falls in patients. And it's also to reduce the energy consumption of the amputee when they're walking. The microprocessor knees can be used in conjunction with the microprocessor feet, or you could use the microprocessor knee and just a mechanical foot. Again, they have sensors that actually detect whether the knee is in full extension or flexion, that automatically adjusts the resistance of the knee. So there will be a different resistance as the patient is walking on ramps versus stairs versus normal walking versus sitting down in a chair. So it depends on how much weight the patient has, how much the toe is loaded, and what is the flexion angle within the prosthetic knee. But we can actually program these feet and knees once we have actually fit them on the patient. So we can actually program to reduce or increase the resistance as needed or as is applicable to the patient. With the increased stance control, they will have increased stability and function, so the patient can walk on different walking surfaces as easily. Again, we have to understand that these are all need to be, some of these are still considered as not medically necessary for the patient, and they are considered experimental or for investigation purposes. So we need to be careful what the patient's capacity is to be able to use these. So the next one in our high technology today is the myoelectric hand. Again, the slide kind of shows you different parts. Basically, the myoelectric control prosthesis is an externally powered prosthesis, so there's no internal inbuilt stuff here. There is actually electrodes that are positioned within the prosthesis, but external to the patient's arm, that can actually detect different muscle signals as the patient tries to use their original muscles. And by detecting those signals, they will generate different hand movements, hand or finger movements. So the myoelectric technology does use these sensitive electrodes to read these activities in specific muscle groups. And they send the signals to the processing units to get the outcome of the specific function. They do have the added benefit, and I have a couple of slides forward, or actually the next slide itself, where it shows the proportional control, which allows the system to show, and I will show you this, Just as an example, whether the patient is using or whether the patient is holding an egg versus a rock versus a glass, so they would need different forces acting. You cannot grasp an egg as firmly as you would grasp or hold a book. So that is where your proportional control comes into the picture. But the iLimb is the more advanced myoelectric processor system where you can actually have different finger movements as well. So in the myoelectric prosthesis, which was the previous one, it was mostly where you would have just the thumb and the first two fingers moving in a specific gripping pattern versus the iLimb where each finger will actually move. So again, but it's controlled by myoelectric signals, which use the muscle signals in the patient's residual arm. And electrodes are placed on two specific predetermined muscle sites that will allow that movement. This slide will show you how the iLimb can actually generate different grip patterns, whether you want to use a key or whether you want to hold a ball. So the different grip patterns are actually accomplished using an iLimb here. Again, just an example of different activities and different grip patterns you might need to accomplish these activities. So consider holding a delicate object versus tying your shoelaces versus using the mouse. The other thing I want to talk about here is cosmetic restoration. Cosmetic restoration in prosthetics is when we're talking about pure cosmetic outcome or pure cosmetic replacement. It has no functional mechanical outcome related to it. Most of the times it's for, say, partial fingers, partial toes, sometimes a partial foot, like in this case. It does have some functional result, which is more just basically if you are missing a finger and you are not able to use that hand for support or be your supportive hand, then just using cosmetic restoration helps with that function of being more supportive during activities. The materials used for cosmetic restorations are usually silicone or vinyl. Silicone is most popular. The other new advancements that are coming up in prosthetics is scanning and 3D printing. So initially, in the good old days, even now, we still use plaster. So we actually have to take a cast of the patient and make a plaster model that we have to work on to make these prostheses. But the technology that's been more popular in the past 5 years and more coming up is the scanning process, where if you see the picture on your left, it's where there's a scanning device, and it's getting more and more smaller. So the scanning device we are currently using is actually just attached to an iPad. So I can just move the iPad around and get a replica of the patient's residual limb or any part of the body on the computer as an image. I can then, like you see in this picture, work on that image on where I want to put pressures, where I want to reduce pressures, and accordingly make a model of a socket. This system is very easy to use because it's a portable scanner that you can carry around anywhere you go. It's less messy, so you're not having plaster all over the place. Modifications on the computer can be done easily within a few minutes. And then the image is sent to an outside fabrication place where a 3D printer can print this socket for you within a few minutes. So the entire process can be done within a day versus where it used to take us a week to do it before. Some other 3D printed prostheses, and I don't know if you guys have heard about these, but 3D printed hands, especially for younger children, are becoming more and more popular. They are much cheaper and mostly targeted for developing countries. They have more mechanical functions, but very less cosmetic functions than regular prostheses. And currently, they're very popular just for like partial hands or where majority of the arm is still present. So it's not for very high-level amputations. The other advancements for or in prosthetics is adjustable socket designs, where when we spoke about this socket that fits on the patient's residual limb, I kind of briefed you a little bit about how uncomfortable it can be, and hence the fitting of the socket is very important. There's multiple different companies that have come up with adjustable sockets. So basically, they just look like different struts that can be adjusted depending on how much tightness or looseness the patient wants. This is very effective, especially for patients who have volume fluctuations, so where our limb shapes can change. And it does change even for all of us. If we realize, your rings could be tighter in the morning, but they get looser during the day. So our body fluctuates a little bit, which we don't realize, but amputees do realize that very effectively when they wear a prosthesis. It does have added comfort because of the reduced contact and the reduced pressures. And the latest that, again, I don't know if you guys have seen, it's all over UCSF News, is osseointegration, where this is actually a procedure where there's an implant that is fitted in the residual limb, in the medullary canal of the residual limb, with a component of the implant protruding out of the skin. And in this case, that implant or that strut is directly attached to a prosthesis, and there is no socket involved at all. Like in this case, you can actually see this pin coming out of the skin, and it's a permanent thing that's popping out all the time. But there is nothing coming over the residual limb. So people who cannot use prosthetic sockets due to either skin infections or skin irritations, or very short residual limbs, and/or volume fluctuations causing socket fit issues, this is a great benefit for them. The main risks that are involved with osseointegration are infection or bone loss or bone fractures. So you have to be very careful when you're doing these. Prosthetic covers are also very latest. So if you see these on the right side, these are very unique, customized prosthetic covers that actually match the amputee's personality. So you have a lot of patients who want like different colors, funky designs on their prosthesis. I don't think we rarely get amputees now who say, I want a prosthetic leg that looks like my other leg. We used to 10 years ago, but not anymore. They actually, they want to show it off. So they don't want these beige-looking, unrealistic-looking prosthetic covers. So these are the new cool ones out there. So that's pretty much all I have for new advancements. We will be welcoming questions, but I have a really nice video I want to share with you before we start with questions. So I hope you guys enjoy this video. Basically talks about our FLS service that Dr. Pascal spoke about.
All across San Francisco, new ground is being broken to improve the care of amputees, led by the UCSF San Francisco General Hospital Orthopedic Trauma Institute. The clinicians at the OTI have established a functional limb service and are producing a patient tutorial video series. These videos will highlight the patient experience at every stage of the recovery process. They will help to educate and inform expectations for those who have suffered traumatic limb injury and limb loss. Patients will get to see how the process of getting a new prosthetic limb works, and will be given an idea of what to expect as they begin working with their prosthetist. They will get a chance to see how their new limb is made and how it's customized specifically to them. They'll see patients, just like themselves, take strides toward reclaiming the mobility and independence of their pre-amputation lives. They'll get to hear patients, past and present, share their experiences and advice.
It's something I was not expecting. I was not expecting, was not thinking, that this was going to happen. And when I actually stood up, it was all I could do, not to just start bawling. all the emotions of the reality of it, you know, of actually standing up and realizing that life was about to change, you know, and that life is changing. It's not about to, it is changing. That was a huge moment, you know, huge moment there.
The videos will also offer easily accessible tutorials on all aspects of living with a prosthetic limb. This series will feature glimpses on what to expect from the physical therapy portion of treatment and will provide basic physical therapy tutorials. Finally, former patients will share their success stories, inspiring present and future patients as they travel on their own road to recovery.
The physical therapists and the occupational therapists are some of the best people you're ever going to meet. So they're going to push you, they're going to ask you to do things that maybe you don't want to do or not comfortable for you to do. But the more you can work with them, the more they will work for you. A smile, a please and a thank you, an appreciation of what they do. It's amazing what it makes their day better, it makes your day better.
Once completed, this open source video series will be available to anyone, anywhere in the world.
So thank you guys for coming here today. And if you have any questions, we'll be more than happy to answer. So the FLS, the Functional Limb Service, comprises of multiple different specialists, like Dr. Pascal was talking about. It has orthopedic surgeons. The ones in the picture are prosthetists, physical therapists. So we have medical students and even actually high school students come shadow us all the time. We welcome students to come down, understand what we do, and similarly, they have for like physical therapy and other places. So we encourage them to come down, understand what it is that each department does in their own way, and then whatever interests them, they can kind of follow that direction. So you're asking, once the amputation is done, how long does the surgeon actually follow up with that amputee? As long as is needed. Most surgeons prefer to see that amputee through the entire stage of rehab, for them to go through like the shrinker, limb guard phase, as well as the prosthetic fitting. So right before the prosthetic fitting, right around, the surgeon will usually follow up with that amputee mostly every couple weeks or every 3 to 4 weeks as needed. And then at some point, we will all see them together at the FLS clinic. So we have, in one of these FLS clinics, we will actually have 5 different people attending to that amputee almost together, so in one room. And we will try to come up with a treatment plan of setting up goals for that amputee, understanding what his prosthetic requirement is, what his therapy requirement is, and accordingly set up time frames for that. But the orthopedic surgeon will also want to see him even after the prosthetic fitting to make sure everything is accomplished as planned. Is that correct?
So just to mention that now we're in a unique situation where we do have the FLS service. Now there are other places that don't have the advantage of having a whole team of people who really feel that they're dedicated to providing this comprehensive continuum of care. So in other centers, you might only see the surgeon at the time of amputation, and then they make sure everything is healed, and then they potentially can hand it off to the prosthetist or another rehab doctor or something. But for us, we do it like Artie says, we see everybody together. When they're there for their post-op check for their suture, we see them all together. We're all in the same room. When we start to move towards fitting, we're all there together. And I think that's what makes the difference between having it done as a team and making it effective versus sort of handing it off in a stage process from one professional to another. So that's a really good question.
So you want to understand what the prosthetic components are actually made out of? Yes, those are carbon fiber components. So all the black devices that you saw, like in prosthetic feet, those are all carbon fibers. So they are very high strength, durable carbon fiber that, depending on the patient's activity. So these prosthetic feet, say for example, you've chosen to go with a Sprinter or a Blade Runner kind of a prosthesis. Even within that, you will have different levels depending on the patient's weight and his activity level. So the keel stiffness will slightly change depending on the patient's weight, but they are all made of carbon fiber. The pylons or the rods that you saw are usually aluminum or titanium, again, depending on, for like a K1 level who's not going to be a very active amputee, we will probably choose an aluminum, making it lighter weight, versus a K3 or a K4, we'll probably go for titanium. So those are the other components. The other parts of it, like the foot cover, is usually made out of just a polyurethane foam. Mostly, the sockets are made out of carbon fiber, again, to give them strength. So everything where it's any part that's going to take the load of the prosthesis or the load of the patient is mostly carbon fiber. That's a really good question. So all the microprocessor feet and the knees actually have to be plugged in for charging, depending on how much you use them. So most active users are recommended to plug them in every night and to charge them for a good 12, 14 hours of use the next day. Some prosthetic knees that are microprocessor controlled also are operated on batteries. So they have like a lithium batteries, very similar to what you use in your cameras, that you can actually replace, and you can keep the other battery on charging. They come with car chargers, just like your phones. So we have patients sitting in their car plugging it in. So they're pretty cool, but good question, yes. It's getting there. Currently, not. It just depends on how many, like what your level of amputation is and how many joints you're missing. In arms, it's a little bit more difficult than it is in legs because you're looking at more intricate movements and more tactile functions. Any prosthesis you're going to put on the residual arm, you're going to miss the tactile, the sensations. But if you're missing a wrist, an elbow, and a shoulder, then it's probably 3 joints that you're going to have to prosthetically replace. So it gets a little bit more complicated. But there is a lot of research going on to basically get input from your brains and be able to use it more effectively. But it's not there yet. It's still a lot under research. So you're asking if there is any amputees who could be a younger amputee and a K4 level, but for some reason could not use a prosthesis. Now, there could be situations where if it's, say, a really young amputee, in that case, and they're not able to they will not be prosthetic candidates because of certain other medical reasons, but that would be a very temporary thing. So at that moment, we might categorize them as a K0 due to certain temporary conditions, which, say, it could be a pending surgery or something to that effect, and then once that is rectified and fixed, then they will become K4. Most of our pediatric population, most young kids are all K4s, just because they are so active. It's hard to bind a young child, right? So, yes. So most amputees, especially the transtibial or the amputees below the knee, can drive pretty easily. The above the knee amputees probably find it a little bit harder, but they can still drive. It takes a little bit of a compensatory movement for them to drive. And just to give you an example, the movement in the foot and the ankle that I was talking about, it's all weight-activated movement. So it's really difficult. If I had a prosthesis and I was just sitting here, I wouldn't be able to just move my foot on wishful thinking. It would be when I put my weight on that foot that it's actually going to help me move. So it's all weight-activated, and it's not just by thinking about it. So technically, when you're driving a car and you expect to push down on the pedal, it's not going to just happen. So it's mostly compensated with your more proximal, like your thigh muscles or your knee. So it's kind of a compensatory. It's not going to be just like we do, but it's amazing how people adapt to that, and they can do it very easily. Right. So that's a really good point you bring up, because like I was saying before, With prosthetic arms, it's very different from prosthetic legs. If I was an amputee with one of my legs amputated, I need to have a prosthesis to walk. So it's more an essential thing. And the acceptance to that, the adjustment is much easier and much faster. So the rehabilitation is faster as well. When it comes to upper extremity, whether it's partial hand, wrist, and it kind of gets more difficult as it goes more proximal. But like I was saying, our functions with our hands are coupled. I mean, one is your actual functional outcome of holding things using your hand, and the other one is actually feeling for things, which the prosthesis doesn't do for you. So you're already missing out on that one function. As soon as you put a prosthesis over your residual arm, you're gonna resist, or you're gonna restrict that feeling. And that, I have heard, is the biggest drawback. They would rather feel for things than actually be able to function with it. Again, depending on what kind of functional outcome they're looking for from the prosthesis, it's important to understand. A typical differentiation between upper extremity prosthetics is cosmetic, mechanical, and the myoelectric. So obviously today we just spoke about the myoelectric prosthesis, which is all the fancy stuff. But there is just the cosmetic, and we know a lot of people who would do that. So if they wanted the arm just as a support, as they're, say for example, eating, they just want a support to use for their plate, to hold their plate, or something like that, then they would have just a cosmetic arm. A mechanical is a body powered. So they have like a harness and everything, and they could potentially, instead of having actual real looking hand, they would just have a hook, which a lot of farmers opt for that because it looks funky. It looks like a metal hook, but it's very functionally, effective. So that really can depend on what was provided. And in spite of all of that, we have seen a lot of non-acceptance with upper extremity than we have seen with lower extremity prosthetics. So it's pretty common to see that. Or sometimes some of them will just use it for certain activities, but they don't like to keep it on all the time. So that has been the case.
Okay. If you have any other questions, we're here for a little bit.
Thank you.